It is 6 o'clock. Good evening and welcome to tonight's webinar, Advances in Colorectal Cancer, Screening, Management, and Current Research Highlights. We are putting on this webinar in recognition of March being Colorectal Cancer Awareness Month. Everyone understands that colon cancer remains a significant public health problem. It is the #2 cause of cancer death in the United States today. Thank you for taking the time to join us. I'm Richard Alexander, the Chief Surgical Officer of the Rutgers Cancer Institute of New Jersey. It is the state's only NCI designated comprehensive cancer center. Some housekeeping issues for this evening. Number one, please note that everyone has been muted on entry to the webinar. This event is being recorded for educational purposes. To participate in the question and answer session later in the program, please submit your questions via the chat box at the bottom of your screen throughout the presentation. If your question is for a particular speaker, please indicate their name with your question, and we'll do our best to accommodate everyone's questions at the end of the presentations. The webinar tonight features a number of experts from the Rutgers Cancer Institute of New Jersey, as well as the Rutgers Robert Wood Johnson Medical School and RWJ Barnabas Health. We're going to start tonight's program with a presentation by Dr. Amy Tyberg. She is the Associate Director of Endoscopy, Director of Therapeutic Endoscopic Ultrasound, and the Associate Director of the Pancreas Program at the Rutgers Robert Wood Johnson Medical School, and she will be speaking on cancer screening and prevention, new guidelines and techniques. Dr. Tyberg.
Thank you so much. Thank you so much for having me. It's really my honor to be here talking about this very important topic of current colorectal cancer screening guidelines and techniques. Next slide. So as we all know, colorectal cancer is a very important and significant public health problem, as Dr. Alexander mentioned, with a high incidence in the US, both amongst women and men, and what's especially concerning, a rising incidence, both in individuals age 50 and over, but also now in individuals younger than age 50. Next slide. One of the most important things about colorectal cancer is the pathogenesis. We know that most colorectal cancers develop through what's called the adenoma-carcinoma sequence, meaning they start off as small growths or polyps and slowly develop into cancers over time. And this is so important because it allows us to intervene and prevent cancers by removing these precursor lesions. Next slide. And that really is the basis of screening. The screening for colorectal cancer basically has two focuses. One, to identify and remove these precancerous polyps before they become cancerous, resulting in less cancer and less mortality related to colorectal cancer. And two, to be able to detect cancers in earlier stages, which also results in lower mortality rates. Next slide. And these are the studies that validate that concept. So on the left is a study from the New England Journal of Medicine looking at patients who underwent colonoscopy with polypectomy and comparing their incidence of colorectal cancer with the expected rate of colorectal cancer in the general population using 3 comparative data groups. And as you can see, much lower incidence of cancer in those who underwent successful screening. On the right, similarly, this is another study in New England Journal of Medicine looking at mortality from colorectal cancer among patients who underwent screening and had either no polyps or adenomas identified or had their adenomas removed compared to expected mortality from colorectal cancer using SEER data. And as you can see, again, improved mortality in those who successfully underwent screening. Next slide. Similarly, this is a study that shows that screening leads to the ability to detect cancers in earlier stages. As you can see here, in the patients that underwent screening, higher numbers of early stage cancers compared to those who did not undergo screening, who had much higher rates of more advanced cancers. And on the right, you can see that this translates to better survival in those that had earlier stage cancers detected. They had higher rates of survival than those that did not undergo screening and had later stage cancers detected. Next slide. So we know that screening is beneficial and results in decrease in mortality, but who really should be screened? And there are a whole bunch of different guidelines from lots of different societies. I know this slide looks very confusing, but ultimately it all simplifies into two basic recommendations. Next slide. That everyone should begin screening in average risk individuals at either age 45 or age 50 and continue through age 75. And then after age 75, the recommendation is to continue screening if you're in good health with a life expectancy of greater than 10 years, or it's acceptable to also individualize the decision to continue screening patient on a patient by patient basis. Next slide. So why the discrepancy? Why do some guidelines say 45, some say 50? And the reason is that actually the rates of colorectal cancer are rising among individuals less than 50 years of age. So on the top bar, you can see the slowly rising incidence of colon cancer in individuals under the age of 50. And on the bottom, even faster increase in the rates of rectal cancer in individuals under the age of 50. Next slide. So then why not screen? Why don't all the guidelines suggest starting screening at age 45? And the reason is that while there are clear pros to screening younger individuals, there's also some cons, specifically that it takes a significant amount of resources to screen what would be an additional 21 million individuals between the ages of 45 and 49. And it also may detract from efforts to screen individuals age 50 and older. However, it is the newer guidelines that are recommending earlier screening ages, and I do think we're going to see more of a shift as the other societies update their guidelines to starting screenings a little bit earlier. Next slide. What about high-risk patients? We know that a large percentage of US adults have either a first or second degree relative with colorectal cancer, and we know that those individuals are at much higher risk of developing colorectal cancer than those without first or second degree relatives. In addition, we know that the risk of colorectal cancer increases with earlier age of diagnosis of the relative, and you can see the relative risks on this chart on the right here, that it gets almost 3.5 or 4 times the general population once you start to get first degree relatives with that had colorectal cancer at younger ages. Next slide. So the guidelines for high-risk patients are a little bit different, and here we see generally consensus amongst all the societies that the recommendation is to start screening a little bit earlier, either age 40 or 10 years before the youngest effective relative. And in addition, shorter intervals between screening tests. So for colonoscopy, it would be every 5 years as opposed to the traditional every 10 years. Next slide. So now that we know who needs to be screened, the next question is how should we be screening individuals? And again, there's a little bit of discrepancy among the different societies and the guidelines, although what is very clear is that colonoscopy and fit testing are the best and the gold standard, and everything else is either second best or some of the guidelines second and third best, depending on how many tiers they split the recommendations into. Next slide. What is undisputable is that colonoscopy remains the gold standard. It's really the only single step screening test where you can have both a diagnosis and therapy all in one step. I think most of us are familiar with colonoscopy. You can see an image of what a colonoscope looks like, and it goes through the rectum, looks at the entire large intestine start to finish in order to identify, next slide, precancerous polyps, which can come in a variety of shapes and sizes, can be found anywhere throughout the large intestine. Next slide. And when they are identified, they can be removed right then and there through a variety of different techniques. And here you can see examples of polyps that are identified and removed right at the same time. And on the right, you see no evidence left of precancerous cells. Next slide. And this clearly results in decreased mortality. These are some of the larger studies looking at colonoscopy and the risk of colorectal cancer mortality and incidence. And you can see across the board decreased risk in those patients who underwent screening with colonoscopy. Next slide. And again, this actually comes from the newest published guidelines earlier this year, just kind of summarizing some of the largest studies looking at colonoscopy and the benefits of screening. And you can see across the board dramatic risk reduction, mortality benefit. So colonoscopy is certainly an excellent screening test. Next slide. However, no test is perfect, and colonoscopy does have its own set of complications. I've listed some of them here, but overall, the complication rates are very, very low, and the benefits far outweigh the risks. Next slide. Stool tests are also important in colorectal screening, and there's really two main types, the FIT testing and the MTS DNA testing. FIT testing, or fecal immunochemical testing, detects microscopic blood in the stool, and MTS DNA testing, which for those of us who watch TV and have seen the commercials, probably we would recognize more as Cologuard, looks not just for microscopic blood in the stool, but also a variety of different DNA mutations. And these stool tests have several advantages. They're safe, they're non-invasive, they're painless. They do not require the patients to take a bowel preparation ahead of time, which means they're convenient, they can be done at home, and they're not affected by diet and medications the way some of the previous fecal occult blood testing was. However, they are two-step screening tests, meaning that a positive test requires an additional follow-up colonoscopy, and they can be expensive if they are not covered by insurance. Next slide.
Amy, we have about just 1 minute left.
Okay, so this is a study, I'll just go very quickly, meta-analysis, 19 studies evaluating FIT testing. You can see pretty excellent sensitivity and specificity. Next slide. This is similar. This is a study that incorporated about 10,000 patients, showing pretty excellent sensitivity and specificity for the MTS DNA. However, the reason that this is really a second-line test and not part of the gold standard is that it does have quite a high false positive rate, almost 10%. Next slide. I'm just going to spend one slide here talking about some of the other options, CT colonography, colon capsule, both also two-tiered tests, meaning that if a positive test is identified, a follow-up colonoscopy is needed. But unlike the stool test, these tests do require bowel preparation ahead of time, which means that if you're doing two tests, that means two bowel preparations, and they're generally considered only approved for those who cannot undergo gold standard testing. Next slide. And this is just a summary. I'll just leave it up here for a couple seconds since we're a little short on time, summarizing the characteristics and the pros and cons of each of these different screening tests. Next slide. So in conclusion, colorectal cancer incidence is increasing, also not just in those over 50, but in younger individuals. The adenoma carcinoma pathway gives us unique opportunity to prevent cancer by removing precursor lesions. Screening has been shown to decrease mortality by identifying and removing precursor lesions and diagnosing cancers in earlier stages. Screening should begin at age 45 or 50 in average risk individuals and younger in high risk individuals, and should continue through age 75. And colonoscopy and FIT testing are the gold standard screening tests, with MTS DNA, CT colonography, and colon capsule being second and third line options. And I will stop there.
Dr. Tyberg, thank you very much. That was a beautiful overview. And next we have Dr. Dan Feingold, who will discuss the evolution of minimally invasive surgical techniques for the treatment of colorectal cancer. Dr. Feingold is the chief of the Division of Colorectal Surgery at the Rutgers Robert Wood Johnson Medical School and the Rutgers Cancer Institute of New Jersey. Dr. Feingold.
Thanks very much for the introduction. I always enjoy contributing to March colorectal cancer awareness initiative, so this is my pleasure. To me, I find this a very interesting topic, something you can probably talk well over an hour. There's actually entire chapters written about this topic, and we're going to condense this in altitude to just a few minutes. I have no disclosures presently, but I need to say that I, in the past, was a consultant for Covidien, then US Surgical, as well as Ethicon and Applied Medical, and I'll be showing some pictures of their products in the next few slides. So if we can advance the slide. We should consider, as we're talking about minimally invasive techniques, these are challenging operations. This is the definition of advanced laparoscopy. With that in mind, it's very important to keep in mind that the fundamentals of oncologic surgery are the same, regardless of how the surgeon approaches the operation, whether it's open or laparoscopic or robotic or other. The pillars of this approach in terms of cancer surgery is what we call it. It deals with margins, en-bloc resection of involved organs, an adequate nodal harvest, limiting the trauma to nearby structures, and I would also add, of course, the no-touch technique. These are all the milestones and the important parts of cancer surgery, regardless of your approach. Peter Marcello up at the Leahy Clinic is quoted often as saying this many years ago when he was at Cleveland Clinic, that good open surgery will always be bad laparoscopic surgery. And those of us that do these operations routinely in laparoscopic fashion recognize this, and we still think this is very relevant, that at the end of the day, you need to be doing a good cancer operation. With that in mind, and next slide, please. When we're talking about minimally invasive surgery for colorectal cancer in particular, the story started back when the laparoscopic revolution was underway in the field of gallbladder surgery, and ultimately, this led to animal studies, then cadaver studies, and then finally operations on human patients, first published by Jacobs in 1991, and then a few months later, also in 91, by Dennis Fowler, considered to be one of the master early laparoscopists. And they really established that this is possible and it's safe and feasible. Of course, in the mid-90s, there was a number of publications, first from Jim Fleshman at Washington University, raising oncologic concerns specifically related around port site recurrences, that patients, a very few number of patients nonetheless, were found to have recurrence of cancer at the location of the abdominal wall ports. This essentially put in place a moratorium on performing colorectal cancer surgery in this country laparoscopically until there was evidence, level 1 evidence available supporting that it was safe and oncologically sound and so forth. And this led to a string of trials that you can see as listed. In terms of colon cancer, one of the earliest trials was by Jeff Milsom, then at Cleveland Clinic. This was followed by Antonio Lacey's landmark paper. This was what's now called the Barcelona trial, followed by the Calor and Classic trials in Europe, and then ultimately culminating in what's called the COST trial, although it had very little to do with dollar cost. And this was the US trial dealing with laparoscopic versus open colon cancer surgery. This body of literature clearly shows that the two approaches are adequate and comparable in terms of laparoscopic versus open surgery in the setting of colon cancer. There's mature long-term data, and this has really put to rest the issue of colon cancer and the applicability of minimally invasive techniques. Rectal cancer is a little bit more complicated story, multiple trials as listed. The two last trials, ACOSOG Z6051, which was Jim Fleshman's trial, and then the Australasian trial a la carte. These, when you look at the details of their analyses comparing laparoscopic to open rectal cancer surgery, demonstrated that when you look at a composite score related to things like the circumferential resection margin, negative distal margins, and the quality of the total mesorectal excision, the laparoscopic groups did not do as well as the open groups. And this raised certainly eyebrows. Having said that, we now have clinical data that's available with 3 as well as 5-year follow-up, and it shows comparability and equivalence between the two approaches in the setting of rectal cancer. And then finally, the ROLAR trial added robotics to the mix and was a randomized trial, very nicely powered, comparing straight laparoscopy to robotics, and demonstrated, again, oncologic equivalency. And so we've gone from a period of knowing that we can do it safely to a period of moratorium and disbelief and pushback to now we have acceptance in terms of the minimally invasive platform. Next slide, please. And these are 2 papers that were published in Diseases in Colon and Rectum. I actually formulated these recommendations. I was the senior author on these papers. This is an endorsement by our national organization, the ASCRS, dealing the upper part of the slide dealing with colon cancer, and that minimally invasive surgery is the preferred approach for colon cancer. And then that actually was published in 2017. We're actually finishing the final touches on an update of that paper, which will be published at the end of this year. And then the lower part of the slide deals specifically with rectal cancer. And the wording that we chose to use was that laparoscopic TME can be considered in the setting of experienced surgeons with technical expertise. And this idea of can be considered is just re-emphasizing the point that the composite scores in 2 of the trials were somewhat inferior to the open approach, yet the clinical data, like we talked about, supports laparoscopy as a go-to approach for rectal cancer. Next slide, please.
Dr. Feingold, we have about a minute left.
Sure. So we're just going to finish up here. These are common and they're intuitive and proven improvements or benefits of laparoscopic surgery. Next slide, please. This is the just a nice picture of why minimally invasive surgery might have systemic improvement over open surgery. You can see here this is a classic study done where mice were injected with tail vein injections of cancer cells after they underwent either anesthesia control, laparoscopic surgery, or open surgery. You can see that mice that underwent open surgery had significantly more implantation of cancer. And this led to a large body of research in Larry Whalen's lab demonstrating angiogenic factors, growth factors, and interleukins that all have alterations that are significantly worse after open surgery. So there's some basic science behind this rather than just clinical outcomes. Next slide. There are other platforms other than straight laparoscopy that we should be aware of. This is a hand-assisted technique where the surgeon actually can instill their hand inside the abdomen and still do the laparoscopic surgery, and it improves our ability to do advanced and complex procedures. Next slide. Another platform that's come to market is what's called single port laparoscopy. It can be done through laparoscopy as well as the robotic platform you can see here in the lower picture. These are very difficult, and the adequacy of these operations in the setting of cancer surgery is really unproven. But the robot in particular is an evolving technique that we should keep in mind, and I think we'll be looking for future improvements. Next slide. Another update is the NOTES surgery, natural orifice surgery. I include this. It's not really relevant to cancer surgery at this stage, but there are improvements on its way, and there's technology advancements that are in the pipeline that may at some point allow us to approach cancers with this kind of platform. Next slide. And then this, of course, is robotic surgery. There's significant benefits with some drawbacks as well. But this is now the 3rd generation of the Da Vinci system, and it's really becoming a very versatile go-to way of operating on colon and rectal cancers, especially cancers in the low pelvis, like rectal cancer patients. Next slide. And this is the last slide that I'll talk about. These are newer platforms, and they deal with the endoluminal arena. This deals with transanal minimally invasive surgery or transanal endoscopic microsurgery, which is something that we do on a routine basis. I would highlight the efforts of Amy Tyberg, who just spoke, as well as Michelle Cahala, who I see is on this in the meeting as well tonight. They're the interventional gastroenterologists here who push the envelope in terms of approaching these lesions, not as much rectal cancers, but certainly polyps and advanced polyps, and even early cancers. They have access to full thickness closure devices and new devices that stabilize the field in order to maintain exposure and do what they do. And this, I think, is one of the real horizons on how we deal with patients with colorectal neoplasia. And then a final note on TATME, which is a method of approaching the total mesorectal excision through the anus. There's been a lot of talk about this and a lot of studies. It's still highly investigational. There's a significant learning curve related to this procedure. And it's something to keep in mind. If they develop technology that allows us to do this more safely, this may become a go-to approach for operating in low rectal cancers, but we're certainly not there yet. So that's minimally invasive surgery in a nutshell, and it's my pleasure to contribute tonight.
Thank you, Dr. Feingold. We're now going to move on to our next presenter, Dr. Miro Grandi. She is a surgical oncologist and hepatobiliary surgeon at the Rutgers Cancer Institute of New Jersey and associate professor of surgery at the Robert Wood Johnson Medical School. Dr. Grandi. Mule, you'll have to unmute.
There we go. Can you hear me?
Perfectly.
Okay, perfect. Thank you all for having me tonight. It's a pleasure to be here, and I'll get started. Next slide, please. So for colorectal liver metastases, if it's left untreated, the median survival for patients with metastatic disease is less than 1 year. With effective systemic therapies alone, the survival is extended to a median of roughly 24 months. However, with the combination of systemic therapy and surgery, the overall 5-year survival increases to roughly 50%. Next slide. When we think about colorectal liver metastases, we define resectability not by what is removed, but by what remains, even if the patient has bilobar disease. The vascular inflow and outflow, as well as the biliary drainage of the remaining liver, must be preserved. A complete resection consists of purely a negative margin. We want to ensure an adequate future liver remnant to prevent liver failure after surgery. And finally, extrahepatic disease is no longer an absolute contraindication for a resection, such as lung metastases. Next slide, please. In order to achieve resectability, we use 3 methods: decrease the tumor size, increase or preserve hepatic reserve, and combine local therapy modalities. Next slide. The future liver remnant is often calculated preoperatively based on body surface area. This is a determination to prevent liver failure after surgery, and we must have an adequate future liver remnant, which is the portion of the liver that remains after liver surgery. So for a normal liver, we need approximately 20% remaining. For patients with a fatty liver or those who have received systemic therapy, which can lead to fatty liver disease, they must have 30% remaining. And for those with compensated cirrhosis or a patient with chronic liver disease, 40% must remain. Next slide. 2 main strategies can be employed to decrease tumor size. First is systemic chemotherapy, which generally has a greater than 50% response rate. Roughly 15 to 20% of initially unresectable disease can be downsized to resectable disease. And the 5-year overall survival is 33% with systemic therapy alone. Next slide. The second strategy utilizes to decrease tumor size is a hepatic arterial infusion pump. For those patients who have liver-only disease, liver metastases are primarily perfused by the hepatic artery. A catheter is placed into a branch of the hepatic artery, which utilizes chemotherapy directly delivered into the liver, which is largely extracted by the liver during first pass and decreases systemic effects. Small increases in the concentration of FUDR can result in a large response within the liver. This also plays a role in stopping tumor spread beyond the liver, and theoretically is to prevent it from spreading into other organs via the portal flow, such as the lungs and other organs. Next slide, please. The second strategy we utilize to achieve resectability is increasing and preserving hepatic reserve. A procedure called portal venous embolization utilizes our interventional radiologist skills to place embolic material in the branch of the portal vein ipsilateral to the tumor, cutting off blood flow to that side of the liver, and thus promoting hypertrophy or growth of the contralateral side of the liver, which will be the future liver remnant after resection. Next slide, please. We can also utilize portal venous embolization to perform a 2-stage hepatectomy. So as you see in the middle sort of section, there's bilobar disease within this liver. We basically, for patients with extensive but resectable disease, you may have to utilize this 2-stage approach. First, we clear the liver disease on the left side. We then portal venous embolize the right side of the liver and promote hypertrophy of the left side of the liver, and thus perform a right hepatectomy as the final stage. And doing it in this fashion, we ensure that the patient has adequate future liver remnant to prevent post-hepatectomy liver failure. Next slide, please. This diagram basically demonstrates a similar overall survival between a 2-stage approach and a single-stage approach. Next slide, please. Finally, we use the third strategy to achieve resectability, which requires various local therapy modalities. So in addition to surgery, we utilize ablation as an adjunct to surgical resection as a parenchymal sparing technique. We recently acquired a new ablation machine with surgical navigation, which allows us to localize small lesions under ultrasound guidance with ease, and thus allows us to care more effectively for patients with colorectal liver metastases. Next slide, please. So here are a few examples of people we have treated with colorectal liver metastases. So the diagrams on the left, both top and bottom, demonstrate the extent of disease that the patient had. And if you go to the next set of pictures, you'll see after systemic therapy, those liver metastases shrank significantly. And the final picture is a picture intraoperatively after the patient underwent their final stage of resection. This patient underwent 2-stage hepatectomy in conjunction with a low anterior resection to resect all sites of disease. It remains cancer-free 1 year later. Next slide. This patient has a large right-sided colorectal liver metastases who underwent surgical resection, also remains cancer-free 1 year later. Next slide. So robotic surgery is being utilized more frequently in the treatment of colorectal cancer, as Dr. Feingold spoke about. It's improved the visualization, is ergonomically favorable for the surgeon who sits at the console while the robot is a few feet away over the patient and a bedside assistant is present. The robotic surgical system actually augments a surgeon's open surgical skills, and it's for colorectal surgery as well as surgery for colorectal liver metastases. Next slide, please. This demonstrates the excellent visualization in the pelvis. As you can see, the rectum, which is being pulled over to the right, and the lateral sidewalls here. It really has improved our ability to see things in the pelvis, as Dr. Feingold also mentioned, in the deep male pelvis. Next slide, please. And finally, this, as the last slide, I just want to show how we've utilized the robotic surgical system to perform partial hepatectomies and formal hepatectomies here at CINJ, such as patients with the tumors located in the cross-sectional imaging demonstrated to the right of the screen. We continue to grow the minimally invasive program and robotic approaches to liver surgery, and it really has been of benefit to the patients with decreased recovery times. So thank you for your time and having me here today.
Dr. Grandi, thank you very much for that presentation. We are next going to have Dr. Patrick Bolland speak about new systemic therapies for colon cancer. Dr. Bolland is a medical oncologist and an associate professor at the Rutgers Cancer Institute of New Jersey. Dr. Bolland. Patrick, I don't see your microphone showing. Are you there? Patrick, if we can see you talking, but we don't hear any audio. If we need to, what I might do, Patrick, if you need a minute to restore your audio, is go ahead and ask Dr. Hochster to give his presentation, and then we'll come back to you. Okay? So could we advance the slide deck? Would that be possible to do?
Good evening. Yeah, if you can go to my slides, I'll let Patrick talk about the ctDNA. So good evening, and thank you everyone for joining us. I'd like to talk a little bit to start about our colorectal cancer portfolio. Next, please. Next slide. Go back one. So that's our medical oncology team, surgical oncology, which includes some of the people you've seen this evening, and hepatology. Also, we also have a large number of research staff that are helping us with our trials, and we also work with interventional radiology. So it is a multidisciplinary approach for standard of care and also for our clinical trials. Next. And just to make everybody aware, Tuesday morning, we have multidisciplinary GI tumor boards with pancreatic and GI, and liver tumor board Thursday mornings. So any of you who would like to attend, you're welcome to contact Heather G. Next. Continuing on, these are our colorectal cancer protocols. You can see that we have quite a few of them for adjuvant therapy, for post-resection for first line, second line, and previously treated refractory disease. So just want to go through a couple of those. Next. So again, for adjuvant therapy, we've got a couple looking at ctDNA, which you'll hear more about, a trial for MSI high, several in the first line and second line, and then further lines. Next. The first trial I want to talk to you about is the SWOG Commit trial. This is for a national cooperative group trial, and that is looking at first-line colorectal cancer with MSI high status or mismatch repair deficiency. It was just reopened after closing the chemo alone control arm. So now it's single agent anti-PD-1 versus chemo plus anti-PD-1. That is open and can be opened at other hospitals as well through the NCI cooperative groups. Next. And for adjuvant therapy, a similar trial is this one, the Alliance trial for MSI high, that is comparing a standard FOLFOX chemo for 6 months versus the same plus atezolizumab for 12 months. That's for all stage 3 MSI high colon cancer, and that's accruing nicely. So if you have such patients, it would be great to put them on a study. Next. For first-line metastatic colon cancer, we have the Solaris trial, another NCI trial coming out of the work of Kimi Eng at Mass General and Dana-Farber. And this is answering the question, if you give high-dose vitamin D, will patients do better for first-line colon cancer? There's a lot of data to support this. This is a randomized trial of high-dose versus standard dose vitamin D. And so please consider accruing patients for this. In addition, next slide, we have a study looking at a analog of leucovorin that seems to increase the response rate, and that's on hold now. There have been 440 patients accrued internationally to it. We have about 15 of those, and it may be increased to 660. So that's another first-line study. Next. And then for second or third line study, we're looking here at the molecular phenotype of HER2 overexpression. This is randomized to an all HER2 arm 1 of trastuzumab and pertuzumab versus standard care. This is an important subgroup of metastatic colon cancer, HER2 overexpressing, like breast cancer. Next, please. And then for refractory disease, we're looking at this new anti-VEGF1/2/3 inhibitor called fruquintinib. This was positive for both response rates and survival in a Chinese randomized phase 3 trial. So it's being reproduced in the West, and it's 2-to-1 randomization of fruquintinib versus placebo for patients who've had all prior therapy, including either TAS-102 or regorafenib, one of the two. Next. And for more refractory patients, we're looking at a really interesting new drug, a new antibody drug conjugate. This is kind of second generation Enhertu, for those of you who know about that drug. It's using the same payload, but the antibody is to HER3, which is one of the EGFR 4 receptors that can dimerize with HER2 or EGFR, but the main thing is it's highly expressed in colon cancer, so patients that have high expression of this may be susceptible to this antibody drug conjugate. We hope this will work as well for colon cancer as the anti-HER2 conjugate works for gastric and breast cancer. Next. And then finally, this is what I kind of call a unicorn study. We're looking at the KRAS G12C. For those of you who are medical oncologists, you know, like RAS is the undruggable target that we have no drugs to treat. This is one of the very first ones out there that's binding to this cysteine in the C part of mutated KRAS. And this drug, Mertex 849, will be combined with cetuximab to give more activity than the drug alone versus a standard second-line therapy. So we're looking for patients with G12C colon cancer. That's about 5%. So another molecular subgroup. Next, please. And then finally, in honor of Dr. Alexander, the Pericles Trial, which is for all the patients who come to see him with peritoneal carcinomatosis from colon cancer. And this is a very innovative trial that he's chairing, looking at a test of circulating tumor DNA, which you'll hear about more from Dr. Bolland in a moment. But the point is here, we're using it to guide treatment when the CAT scans are very unrevealing for this kind of cancer. Usually they underestimate the amount of disease and disease progression. We hope we can use one of these circulating tumor DNA tests to help us treat people more effectively. Next. Oh, and these are where the red boxes are where we're using the ctDNA to make therapeutic decisions, either to stop or to restart if it starts to go up again. Next, please. So patients with colon cancer are living longer than ever. I mean, many years today, even with metastatic disease, and molecular subtyping is necessary for management. Those molecules that are listed there are really key factors in determining treatment today for metastatic colon cancer. We're hoping to use ctDNA to give us new insights, and we're testing new drugs in late line setting, and they are very promising today. So we hope that we will be able to extend survival even longer.
Howard, thank you very much. That was a terrific overview of our portfolio of clinical research studies in colon cancer. I do want to mention for the listeners that that was Dr. Howard Hochster, who is our Associate Director for Clinical Research and Director of GI Oncology at the Rutgers Cancer Institute of New Jersey, and he's Director of Clinical Oncology Research for RWJ.
Well, I just stepping in for Dr. Bolland.
We're going to go back now to Dr. Bolland, if we can take our slides back to his presentation. Dr. Bolland is, as I mentioned, a medical oncologist, associate professor of surgery, and at the Rutgers Cancer Institute of New Jersey, and we'll be talking about advances in colorectal cancer with reference to circulating tumor DNA. Dr. Bolland, we're eager to see if your microphone is now operational.
This is me. I guess you can hear me now here.
Patrick, are you there?
Yep, I'm here on the phone.
Perfect. All right, great. Just turn down turn down your microphone on your computer so we don't have an echo. That's perfect. Thank you very much.
Yeah, great. Perfect. So sorry about that. I don't know what's going on with that, but all right. Well, here I am. Hopefully you can hear me. All right. So I'm going to talk a little bit about ctDNA, tiny bit about what we know about it, and then kind of what's going on. So what is ctDNA? So basically, these are fragments of DNA that can be detected in the blood, and the T refers to tumor. So you can detect either tumor DNA or DNA from other healthy cells in the bloodstream. And the thought is that these are either secreted by cells or released when the cells undergo death. And so essentially, from these fragments in the blood, we can detect tumor-specific mutations, other tumor DNA changes like amplifications or methylation. Next slide. And so in the course of colorectal cancer, there are multiple potential opportunities to intervene. And so one of the issues we have is that it takes a certain amount of cancer to be present before we can actually detect it. So there's a limit to how good our scans are, how good our eyes are, how good other sort of standard tests are. And there's definitely some evidence that ctDNA can detect things far before a scan does. So there is work currently being done looking at detecting actually cancers earlier on the whole, and this is very much a work in progress, not ready for prime time at all. But other places that we think we will, that we're using in studies and we think we'll be able to use this in the future is when a cancer is diagnosed and someone gets treatment before surgery, helping us to assess response and how can we maybe modify treatment after surgery. I think this is one of the big spots now is can we modify our treatment or can this help us better inform treatment decisions and how we counsel patients? And then possibly even pick up recurrences earlier when patients do unfortunately occur. At the time of recurrence, the thought is we can again maybe use this to help monitor response earlier, and then also to pick up alterations that might guide us to novel therapies. Next slide. So in essence, what I just described is really one of the big goals is to use ctDNA to better calibrate our therapies. So when we look at recurrence risk for patients, the thought is patients who have a negative ctDNA assay, we may be able to de-escalate some of our standard treatments. And then when they have positive ctDNA, we know the risk of recurrence is considerably higher. We may ultimately be escalating treatments beyond what would be otherwise standard. Next slide. So how well do these assays perform? So this is data from a few years ago, and there are ongoing efforts to collect data and really learn more and get more precise on this. But this is data on stage 2 colon cancer patients who didn't have chemotherapy. And on the left, what we see is patients who were ctDNA negative versus positive and their risk of recurrence. So those who were ctDNA negative after surgery did very, very well. Not perfectly, but very, very well. Whereas those who were positive actually did quite poorly. And on the other hand, on the right here, you can see the current way that we assess patients where we look at clinical risk factors and what we would call clinically high risk certainly does worse than clinical low risk, but it pales in comparison to ctDNA based stratification. Next slide. And so this is another way of looking really at the same data. So you can see here on the left is patients who are low risk and they're negative versus positive. And on the right, you can see, so even when we look at what's our gold standard now today, clinical high risk. So patients that are ctDNA negative do considerably better. Like I said, not perfectly. So we still have to incorporate some other factors when we're looking at ctDNA. But clearly it can change things a little bit in terms of how we might consider treatment of these patients. Next slide. So really these concepts and this information has led to a number of efforts. And so in stage 2 colon cancer, there's an NCI study going on right now, the COBRA study that we have open here. And based on the fact that we know in stage 2 colon cancer, adjuvant therapy is of limited benefit for the average patient, and the predictors are really not so great for who's going to recur versus not. This is basically using a ctDNA-guided approach to select the patients where it should be escalated. So essentially, patients are randomized to the standard of care versus assay-directed therapy, where if they're ctDNA positive, we're giving them, this didn't come through, but patients are getting 6 months of a standard adjuvant therapy in hope of improving long-term outcomes. In addition to this, we're participating in another large ongoing study, the Bespoke study, where we're collecting ctDNA in stage 2 and stage 3 patients, really, I think, to better help understand how do we use these assays and how do these assays perform on our patients. Next slide. As Dr. Foster mentioned, the Pericles study is a study that we are recently opened in patients with peritoneal carcinomatosis, and really the goal here is we're using ctDNA to guide therapy and therapeutic decisions, primarily after surgery. And similar to this, there's an ongoing a study that we have open and that is open across the country, Colomate, where we're using a ctDNA platform to identify certain DNA changes to essentially guide patients to therapies in the advanced stage setting when standard treatments aren't working any longer. Next slide. So, so some important issues just sort of high level to draw your attention. So unfortunately, as you can see from those curves, or actually from some other ones that I didn't put on here, ctDNA isn't perfect, right? There's no perfect test. It doesn't pick up every recurrence. And also, from what we've seen thus far, not all positive cases recur. So we still, have to use our best clinical judgment, and that's a big caveat, I think, when there's new technology. We want to use it to every advantage, but we have to rely on some of the standard things as well. It's not perfect also for colorectal cancer, picking up some standard mutations. So there are some things where, so some of these mutations, KRAS and NRAS, we can miss in a small percentage of situations. So we still do tissue testing as our standard especially as a first test. And we don't yet know if all these strategies will change long-term outcomes. I think we're very hopeful though that they will, and that's why we're doing these current studies, but it's important that we get these studies done and we have that information. Next slide. So in summary, so ctDNA is a rapidly emerging technology. It's, the nice thing about it is it's easy access. We're just talking about blood and IV, quick turnaround with these tests. Depending on the test. So some tests you can get back within a week or two. Some tests take a little bit longer the first time around, maybe 3 to 4 weeks, but they're quicker beyond that. And that we're very hopeful this will allow us down the road to optimally utilize and identify treatments. So, potentially allowing for both appropriate escalation and de-escalation of therapies, and then also to find matched and innovative treatments for patients in need. Thank you.
Patrick, thank you very much. That was a beautiful overview of ctDNA. Our next and final speaker tonight, I am pleased to introduce Dr. Salma Jabbour, who is the clinical chief of radiation oncology at the Robert Wood Johnson University Hospital and the Rutgers Cancer Institute of New Jersey. She is a tenured professor of radiation oncology and the vice chair of clinical research and faculty development at the Rutgers Cancer Institute of New Jersey. She'll be speaking about radiation therapy for rectal cancer. Dr. Jabbour.
Thank you for the kind introduction, Dr. Alexander, and the opportunity to speak to all of you this evening. And thank you for sticking around in these late hours. I appreciate your time. Next slide, please. Radiation therapy is kind of a mystery to most people. It's a very small discipline of medicine, of general medicine, general everything, I guess. And we produce radiation therapy to treat and oftentimes cure cancers. In the setting of colorectal cancer, we most often use radiation therapy to really help advance the cure of these patients. But radiation therapy is produced through these complex machines where we generate primarily photon-based radiation that can be very shaped to the patient and is really designed to minimize toxicities while being effective. Next slide. Radiation therapy works through small breaks that are made in the DNA, and these conglomerates of breaks ultimately can cause double-strand breaks, which then lead to difficulty of the cancer cell reproducing, and then ultimately through various mechanisms can lead to cell death, such as apoptosis, cell cycle arrest. And the main method in radiation therapy is abortive division or mitotic catastrophe, in which the cell goes to divide but cannot because its DNA has been injured. Next slide. Radiation therapy for locally advanced rectal cancer is really the primary use of radiation therapy in any colorectal cancer. And these are the tumors that have gone through the muscle wall or into nearby organs or have nodal lymph node involvement in the pelvis. And we learned in very early studies that these tumors had very high rates of local recurrence. And in the early years, we used to develop to deliver postoperative concurrent chemoradiation therapy, which we learned reduced local recurrence, which were pelvic recurrences that were symptomatic or difficult or nearly impossible to cure, as well as improved overall survival. And in 1990, through the NIH consensus statement, postoperative chemoradiation became the standard of care for stage 2 to 3 rectal cancers. Next slide. We have a couple of really pivotal studies that I'll just present very briefly today. This one is the Swedish rectal cancer trial. It's a very old study, but did show, it was some of the earliest data that showed the use of radiation therapy before surgery improved the survival rates and the local recurrence rates, as well as the disease-specific survival, meaning patients having less sign of their cancer coming back. So this was a very important advancement in our field. And next slide. And another next slide, and the other pivotal trial that came out in the New England Journal of Medicine in the early 2000s was also this study that compared using chemoradiation before or after surgery. And this was with modern total mesorectal excision surgery. And we found that this further reduced the rates of pelvic or local recurrences. And also, next slide, also helped to improve the chance that patients would undergo a sphincter preserving surgery, meaning avoiding a permanent colostomy. It also led to fewer complications when radiation was delivered in the preoperative setting. And usually we can use lower doses as well as improving the rates of a complete resection. And so this is the main reason we use radiation therapy currently in the preoperative setting. Next. So we also use radiation therapy, just to kind of give you some general background about other uses of radiation therapies. We often use radiation therapy for a variety of palliative reasons, such as bone metastases, brain metastases, cord compressions, airway obstructions, superior vena cava syndrome, and bleeding from tumors. Next slide. And one common use of radiation therapy is selective internal radiation therapy, or radioembolization. And this is a common palliative procedure in which we deliver these small radiation microspheres into the liver through a transhepatic catheter approach. And this allows for embolization, or blocking off the blood supply to tumors, as well as delivery within the tumor themselves. And we really use this kind of as a last line therapy, but can often help to prolong survival rates. Next. And this really works by selective by this kind of selective blood supply of the colorectal cancers or other tumors that metastasize to the liver, and these are preferentially taken up. The blood supply of these tumors is preferentially from the hepatic artery, in which we deliver the spheres, and this kind of shows the differential distribution of the tumors on the bottom via the hepatic artery and the normal blood supply of the liver via the portal vein, and that's why this treatment can be successful. Next. And other uses of radiation that you may hear about are like the gamma knife radiosurgery for brain tumors, or the cyber knife, where we can give very focused radiation to a variety of parts of the body, such as early stage lung cancer, where the therapy can be curative. Next slide. Next slide. And these are some other examples where we can deliver curative radiation therapy for early stage lung cancers where patients are medically inoperable, or we can very directly palliate a single site of bone metastasis that can be very symptomatic for the patient. So these are really localized therapies that have very reduced side effect profiles and can be given in very few trips to the radiation oncologist's office. Next. And then the unique thing that we have in New Brunswick is the proton therapy. And this is a very important advancement for many of our patients, where radiation therapy is indicated particularly in reirradiation settings, where we give radiation a second time, or in the pediatric setting. And the unique aspect of this is that there is no exit dose. So you can see that at the depth of 25 centimeters on the x-axis, the radiation can be kind of stopped abruptly, whereas most routine radiation given throughout the country can have the so-called exit dose, where the radiation kind of keeps going and can add to potential side effects. Next slide. And one prime example for that is in the pediatric setting, where historic radiation therapy on the top really has the exit dose into the anterior structures, but in the proton setting, we can limit the radiation that's given to the child's anterior structures, and the radiation can be limited to the spinal column where it needs to be delivered. Next. So some take-home points is that radiation therapy is a standard of care for locally advanced non-metastatic rectal adenocarcinoma. It's important for palliation of cancer symptoms, and we have many interesting and exciting technologies available that I'm happy to speak to any of you about. I appreciate your time and attention at this late hour, and thank you again.
Solma, thank you very much. That was a beautiful overview. We are right at the 7 o'clock hour, but we have two questions that I'm going to ask the panelists to stay on for, and we'll just take just a minute or two to ask and get a response. The first question is going to be to Dr. Tyberg, and the question really is, why is colon cancer increasing in younger adults?
I think that's a great question without a great answer. Unfortunately, we're seeing the trend, but why that's happening, I think it's still under investigation. But certainly, it's happening enough that two of the major guidelines have changed their screening recommendations, and I really do think that in the future we're going to see more societies start to change their screening guidelines as well.
Do any of the other panelists have any comments regarding that question?
This has been investigated to a great extent, looking at the mutations and the different molecular profiles of the younger age group versus older patients. And really, there is nothing that you can look at a molecular basis that can differentiate. So it's not like it's behaving like a different kind of colon cancer, like a young colon cancer versus an old. The molecular basis seems to be exactly the same. So I think that the question continues to be a good one, and one that we don't know the answer to, but early screening is really the answer. I think we need to all bear in mind, especially in colorectal cancer awareness month, that colonoscopies save lives. When you find a polyp and you remove it, the person does not get cancer. And that has been proven in prospective randomized trials. We need to get patients to get over their squeamishness and get their colonoscopies. And I won't ask everybody on the call today who's had a recent colonoscopy, but you can ask yourself.
Thank you. Thank you, Dr. Hoxter. The last question that I'm going to ask the panel tonight, and I'm going to ask Dr. Grandi to respond first, then Dr. Jabbour, and then finally Dr. Hoxter. And the question is this: is there a role for using immune checkpoint inhibition after radiofrequency ablation or radiation of metastatic colorectal cancer to the liver? Dr. Grandi, can you start? And then we'll go to Dr. Jabbour and then to Dr. Hoxter.
I'm so sorry.
Say that the reason that we're asking this question is presumably because the radiofrequency ablation or radiation would release antigens into the immune milieu of the liver, allowing for immunotherapy to be more effective. I'm sorry, Earl, to cut you off. Go right ahead.
Oh no, I'm sorry. Can you please repeat the question? I just was having trouble unmuting myself.
So the question is there a role for using immune checkpoint inhibition therapy after radiofrequency ablation or radiation of metastatic colorectal cancer to the liver, potentially looking for an abscopal effect to generate an immune response in the body?
So I am not familiar with any data related to immune therapy to be used after ablation. So I really, based on the information that I am aware of, I don't believe there's a specific role for that. Dr. Jabbour, have you heard anything?
So we know that immunotherapy is very effective in MSI high colorectal cancers. And the question that is being asked is whether or not radiation or radiofrequency ablation plus PD-L1 or PD-1 checkpoint inhibitors are effective. And we suspect that there will be a signal to that answer, but no one has quite proven it yet. I mean, many of the preclinical studies suggest there should be synergy, especially in colorectal cancer, which tends to be a cancer in general when it's stable to MSS stable. That we may not see an effect of immunotherapy, but some recent studies have actually questioned whether or not dual agent checkpoint inhibitors can have a small effect on response rates preoperatively, and we've seen some signal there that's raised the excitement again. I think the real answer is that these studies are still ongoing, and we're still trying to figure out the best sequence and how to best treat these patients with immunotherapy, and if we can generate a response. I hope we will see such a signal in the future.
Thank you, Dr. Jabbour. For the final response, Dr. Hoxter.
Well, there are a number of trials going on about using ablation or radiation to combine with checkpoint inhibitor therapy. And I think may be some role in other diseases than colon cancer. I mean, for MSI high colon cancer, there could be a role eventually, but for your general 95% of other colon cancer, the anti-PD-1 drugs just don't work. And I don't think that adding anything to it is going to make it, any of these kind of manipulations will make it work. I'm hoping that there will be new checkpoint inhibitors that will be more effective for colon cancer eventually. But in terms of, specifically in terms of liver embolization and immunotherapy, there are a number of such trials going on in hepatocellular cancer, primary liver cancer. So I think we will get a signal from those trials in the next year or so.
Thank you very much. It's now 7:06. The program for this evening has been concluded. I want to thank everyone for participating tonight. Those were terrific presentations from our faculty at the Rutgers Cancer Institute and from the Rutgers Robert Wood Johnson Medical School. If any of the people who are listening to our webinar have any questions, you are free to contact Shireen Botros at the email address below for any questions that you may have. And we have an Oncology Access Center number, which I will show you here for anyone who wants to refer or have questions about clinical care and access to our system. Thank you all very much for your attention tonight, and thank you all of the participants.
Thank you, everyone.
Thank you. Good night.
Thank you.
Good night.